Do you know what medical condition gets searched online more than heart disease, more than diabetes, more than cancer? 90% of people who have it say nothing to their doctor for months, sometimes years. They sit with the pain, the itching, the bleeding, and the shame, and they say absolutely nothing. It is not a tumor. It is not a failing heart. It is hemorrhoids, the single most common health search query in the United States, and the single most under-discussed medical condition in the English-speaking world. You will talk to your best friend for an hour about a headache. You will post online about your back pain. But hemorrhoids? Total silence. Complete, stubborn, self-destructive silence. And here is the brutal clinical reality. Your silence is not protecting you. It is not saving you from embarrassment. It is just giving a progressive vascular disease more time to damage your body. Because hemorrhoids do not resolve on their own. They do not plateau. They advance. And by the time most patients finally walk into my office, the condition has been quietly worsening for years. The healthcare system is not going to volunteer this information to you. There is no financial incentive to give you a real explanation and a real solution at a 15-minute appointment. Subscribe to Dr. Waterling and hit like right now. We are building toward 1,000 subscribers, people who want actual answers, not managed symptoms. I am Sam Waterling, 15 years of clinical practice. I see patients every day. I know exactly what it costs a person physically, financially, psychologically, when a treatable condition is mismanaged or ignored until it requires surgery. Today, I am giving you the complete picture, not a surface level overview, not a pamphlet, a full clinical explanation of what hemorrhoids actually are, where they actually come from, what is driving them at the mechanical and biochemical level, what you must stop doing immediately, and exactly what you should start doing today to reverse the trajectory of this disease before it reaches the point where a surgeon is your only remaining option. Let's begin at the very foundation, the anatomy, because if you do not understand what hemorrhoids actually are, everything else I tell you will make no sense. Forget everything you have heard about cold surfaces, drafts, sitting on stone benches in winter. That is pure folklore with zero clinical basis. What is the internal blockage that is driving the venous congestion in your pelvis? The answer, in the vast majority of cases, is your own intestines, specifically a descensus of the intestines, meaning a downward displacement of the bowel out of its correct anatomical position and into the pelvic cavity. In a properly conditioned body, the intestines are held in the upper and middle abdominal cavity by a combination of muscular support from the abdominal wall, ligamentous suspension, and intra-abdominal pressure. When the muscles of the anterior abdominal wall are weak from years of sedentary work, from chronic poor posture, from lack of core conditioning, the intestines gradually descend. Gravity does its work across months and years. The heavy displaced bowel sinks into the pelvis and begins to compress the large venous trunks that run through that space, the inferior vena cava, the iliac veins, the pelvic venous plexuses. Every vessel distal to that compression, every vein below the point of obstruction begins to engorge with blood that cannot drain properly upward. Now here's the clinical detail I want you to pay close attention to because it is something I observe in my practice with striking consistency. Patients who present with hemorrhoids almost invariably have some degree of varicose veins in their legs as well. Not always severe, not always symptomatic, but present. And this is not a coincidence. It is direct anatomical confirmation of the same phenomenon. A system-wide venous congestion driven by the same pelvic mechanical obstruction. The intestine sitting on the pelvic veins is acting as a tourniquet on the entire lower half of the venous system. Everything below that blockage, the rectal veins, the leg veins, the perineal vessels, is operating under chronically elevated venous pressure. You are not dealing with isolated hemorrhoids. You are dealing with a global vascular problem in the lower body. And the hemorrhoids are simply the most visible and symptomatic manifestation of it. The tourniquet analogy is worth making concrete because it perfectly illustrates the mechanism. A tourniquet is a compression band applied around a limb to stop blood flow. It is used in trauma medicine to control life-threatening hemorrhage from a severed artery. If I apply a tight tourniquet to your upper arm and you look at the veins of your forearm, you will watch them swell and become prominently visible within seconds. The moment I release the tourniquet, those veins collapse back to their normal caliber. The venous engorgement disappears completely, not because anything changed about the veins themselves, but because the obstruction was removed and normal flow was restored. Your descended intestine is functioning as a permanent internal tourniquet. It is sitting on your pelvic veins around the clock every day, compressing them with its weight. The hemorrhoidal veins downstream are responding to that sustained compression exactly the way your forearm veins respond to a tourniquet. The logical therapeutic conclusion from this understanding is straightforward, almost elegant in its simplicity. To resolve the venous congestion driving hemorrhoid development, we must either remove the obstruction or lift the bowel back into its correct anatomical position. When the intestines return to their proper location in the abdominal cavity and stop compressing the pelvic vasculature, venous blood can drain upward freely. The hydraulic pressure in the hemorrhoidal plexus normalizes. The stimulus driving continued vein dilation is removed. The disease stops progressing. And in many cases, over months of consistent effort, the existing dilation begins to partially reverse as the vein walls gradually recover structural tone. This is achieved through specific, targeted exercises designed to lift the pelvic organs and restore the muscular support structure that should be holding the intestines in position. These are not generic abdominal exercises. They are movements designed around the specific anatomical mechanism I have just described, lifting internal organ position through engagement of the deep postural muscles, the diaphragm, the pelvic floor, and the anterior abdominal wall in coordinated sequence. Patients who perform these exercises consistently and correctly, daily, without exception, see a reliable halt in hemorrhoid progression. I have watched this outcome repeat in my practice across 15 years. The disease does not vanish overnight, but it stops getting worse. And for a condition with the trajectory hemorrhoids have, stopping the progression is a profound and meaningful clinical result. Now, I want to take you to a second layer of this problem, one that receives almost no attention in standard medical consultations. And that I consider critically important for understanding why some people develop severe hemorrhoids, while others with similar lifestyle factors do not. Directly adjacent to the rectum, lying immediately posterior to it, immediately behind it, is a large triangular bone at the base of the spine called the sacrum. You know the sacrum. It is the solid, hard, flat bone that you feel pressing against the floor when you lie on your back on a firm surface. That hard structure in the center of your lower back, that is your sacrum. The rectum lies directly in front of it, separated by a thin layer of fascial tissue. Now here is the anatomical and physiological detail that almost no physician outside of osteopathic medicine will ever explain to you. In a healthy individual, the sacrum is not a completely fixed, rigid, immobile structure. It has measurable, rhythmic micromovements, small oscillations occurring at a frequency of approximately 10 to 12 cycles per minute that are synchronous with subtle movements of the cranial bones of the skull. This phenomenon is part of what osteopathic physicians call the primary respiratory mechanism. To define that term precisely, the primary respiratory mechanism refers to the rhythmic pulsation of cerebrospinal fluid, the clear, nutrient-rich fluid that circulates around the brain and spinal cord, and the corresponding subtle mechanical movement it produces throughout the skeletal framework, from skull to sacrum. This is a distinct and separate rhythm from your heartbeat and from your breathing. It has its own independent frequency, and it is measurable with trained palpation. This mechanism is not a marginal curiosity. Osteopathic research and clinical experience place it as a foundational parameter of neurological health, endocrine function, and circulatory efficiency. The endocrine system, the network of glands that produce hormones including cortisol, thyroid hormone, sex hormones, and insulin, depends on adequate cerebrospinal fluid circulation for its regulatory communication pathways. Disruption of the primary respiratory mechanism correlates clinically with a wide range of systemic health problems. But what specifically concerns us in the context of hemorrhoids is this. The sacrum, as a moving component of this global system, produces a gentle, continuous micro-pumping action on the venous plexuses of the rectum that lie directly in front of it. Every subtle posterior-anterior oscillation of the sacrum creates a mild mechanical pressure wave through the pelvic tissues, a natural, passive, rhythmic massage of the hemorrhoidal venous networks that assists venous drainage upward through the pelvis. When sacral mobility is blocked through falls on the tailbone, through years of sustained compression from sitting, through old pelvic injuries, through fascial adhesions that have accumulated over time, this natural pump stops functioning. Venous stasis in the rectal plexus increases substantially. The threshold for hemorrhoid development drops. Under these conditions, even moderate venous pressure from intestinal displacement is sufficient to drive significant hemorrhoidal disease. I have seen this clinically many times. Patients with relatively mild postural problems develop severe hemorrhoids because the secondary drainage mechanism, sacral micromovement, is completely absent. The treatment implication is clear. Restoring free sacral mobility is a direct, evidence-based therapeutic target in hemorrhoidal disease. A skilled osteopathic physician can assess sacral mobility through palpation by placing trained hands on the sacrum and the cranium simultaneously and detecting the quality, symmetry, and amplitude of the primary respiratory rhythm. Restrictions in that rhythm indicate fascial tension or joint dysfunction somewhere in the chain from skull to pelvis. Manual techniques to release those restrictions applied to the sacroiliac joints, to the thoracolumbar fascia, to the pelvic floor, and sometimes to the cranial sutures restore the micropump action and dramatically improve venous drainage from the rectum. In my clinical experience, patients who received combined osteopathic work addressing the abdomen, the pelvis, and the cranium in an integrated protocol showed marked improvement in hemorrhoidal symptoms. Reduced swelling, reduced bleeding, improved comfort without any pharmaceutical intervention beyond nutritional supplementation. But you do not have to wait for a specialist to begin addressing sacral mobility. There are effective exercises you can perform at home starting today that specifically target the sacroiliac joint, the joint connecting the sacrum to the large iliac bones on either side of the pelvis, and the ligaments that support and restrict it. I'm going to walk you through these in precise detail because technique matters here. Done incorrectly, these movements miss the target entirely. Done correctly, they produce a progressive, cumulative improvement in sacral mobility that you will be able to feel within a few weeks. The first exercise is performed standing. Stand barefoot on a firm floor. Fix your feet firmly in place. They should not slide or rotate. Now, rotate both legs inward simultaneously with deliberate muscular effort, as if you were trying to screw both feet into the floor like large bolts. Your feet do not actually move, but the rotational muscular tension transmits upward through your tibias, your femurs, into your hip joints, and into your pelvic bones. As your pelvic bones rotate inward with this force, the sacrum is subjected to a stretching, torsional force at the sacroiliac joints. Simultaneously, use the muscles of your posterior pelvis and lower back to push the sacrum backward, as if you were trying to press the back of your pelvis into a wall directly behind you. Hold this combined tension for several seconds. Release. Repeat 5 to 10 times every day. What you are doing is mechanically stretching the sacroiliac ligaments, the dense, powerful connective tissue bands that hold the sacrum to the iliac bones. In most people who have spent years sitting at desks, these ligaments are chronically shortened and stiff. Progressive daily stretching restores their elasticity, improves the range of sacral motion, and reestablishes the conditions for normal sacral micromovement. For those who have never heard the word sacrum before and are uncertain where exactly it is, lie on your back on a hard floor. The bone you feel pressing against the floor in the center of your lower back. The large, flat, solid bone. That is your sacrum. On either side of it are your iliac bones, the large wing-shaped bones that form the sides and back of your pelvis. The sacroiliac joints are the connections between these structures, one on each side of the sacrum. They are the target of everything I'm about to describe. The second exercise is performed lying on your back on the floor. Extend one leg completely straight and allow it to relax. Bend the opposite knee and draw it toward your torso, but here is the critical technical point that determines whether this exercise works or not. Do not pull the knee straight toward your chest. That direction stretches the hip capsule and the gluteal muscles, which is fine, but not what we need here. Instead, pull the knee diagonally toward your opposite shoulder. That specific diagonal vector creates maximum mechanical tension across the sacroiliac ligaments on the side of the bent knee. You will feel a deep pull in the posterior pelvis in the region of the sacroiliac joint when you have the angle correct. Hold the stretch for 10 to 15 seconds. Release. Repeat on both sides. Note carefully which side feels tighter, more resistant, more restricted. That asymmetry is clinically meaningful. It indicates unequal sacral mechanics and unequal venous drainage from the two sides of the pelvic floor. The advanced version of this exercise uses the edge of your bed or a firm sofa. Lie so that your hips are at the very edge of the surface. Allow the straight leg to hang freely off the edge, pulled toward the floor by gravity. This gravitational traction on the straight leg anchors the corresponding side of the pelvis firmly, creating a stable counterforce as you perform the diagonal pull with the bent leg on the opposite side. The sacroiliac stretch is substantially more intense in this position. The straight leg hanging downward can be actively pulled further toward the floor by contracting the hip flexors and quadriceps, increasing the pelvic anchoring force and making the stretch even more effective. Perform the movement slowly and deliberately. Change sides. Again, focus more repetitions and more sustained holds on the tighter, more restricted side. Over days and weeks of consistent daily practice, you will notice the asymmetry decreasing as both sides of the sacroiliac complex become more balanced and mobile. Now, let's move to the biochemistry, the internal molecular environment that determines whether your vein walls can withstand the mechanical stresses I have been describing, or whether they fail under that stress and produce hemorrhoidal disease. Every significant case of hemorrhoids reflects a systemic weakness of connective tissue. This is not a peripheral factor. It is central to understanding why some people develop severe, rapidly progressing hemorrhoidal disease, while others with similar mechanical risk factors remain asymptomatic for years. The vein wall is a connective tissue structure. Its ability to maintain its caliber, its tubular shape under internal hydraulic pressure, depends entirely on the structural integrity of the proteins that compose it. The two key structural proteins of the vein wall are collagen and elastin. Collagen, the most abundant protein in the human body, provides tensile strength. It is the rigid scaffolding that prevents the vein from stretching beyond its normal diameter. Elastin provides recoil, the ability to stretch under pressure and return to baseline when the pressure normalizes. When you see a hemorrhoidal node that is severely prolapsed, dark blue or purplish red, visibly engorged, that bleeds on contact, you are looking at a vein wall that has lost both its collagen scaffold and its elastic recoil. The vessel wall has been reduced to the structural equivalent of a worn-out rubber band that has been overstretched too many times. It cannot recover its shape. It cannot contain the blood within its normal caliber. It will continue to stretch and deteriorate unless you intervene at the biochemical level and give the body the raw materials it needs to rebuild that structural framework. Your doctor is not going to walk you through this at a standard appointment. Not because they do not care, most of them do, but because a 15-minute appointment does not allow it, and because the healthcare system is economically structured around managing symptoms rather than eliminating root causes. There is no billing code for a 45-minute explanation of pelvic biomechanics and connective tissue physiology. There is a billing code for prescribing a topical cream and scheduling a follow-up. Subscribe to Dr. William Lee, hit like, and help this channel reach 1,000 subscribers. Real, complete, clinically honest medical information freely available to everyone. That is what we are building here.